Welcome back, everyone, to another fabulous episode of the Healthcare Trailblazers podcast. I am extraordinarily excited to be sitting today with the wonderful Purva Rawal. Purva is the Chief Strategy Officer at the Innovation Center at CMS. Very, very cool. Been going back and forth for a lot of months. CMS obviously does an incredible amount of work, and a lot of their new initiatives stem from the Innovation Center. So this is excited to hear about all the work of the Innovation Center and how it affects and impacts the work at CMS and the eventual rollout to the entire country and affecting our entire healthcare system. So, Purva Rawal, thank you so much for sitting down with us today.
Mendel, thanks so much for having me. In preparation for this discussion, as to all the listeners, I was telling Mendel that I listened to a few of your recent conversations. I'm looking forward to being a more regular listener now. So I'm just excited to be here to talk with you today about our work at the Center for Medicare and Medicaid Services, or CMS, about the agency's strategic priority to drive innovation that tackles our health system challenges and promotes value-based person-centered care, which I know all of your listeners are always interested in and focused on, and then my work at the Innovation Center to support this strategic pillar for CMS. So I'm looking forward to this.
Fabulous. Well, let's dig in. So take us back. Where'd you grow up? How'd you get into healthcare? Take us through it.
Yeah, probably accidentally, as most people that end up in healthcare policy. But I'll tell you a little bit about myself. I'm a first-generation Indian American. Was born and raised in the suburbs of Chicago, so Midwesterner. Went there for undergrad, grad school. My parents were small business owners, and as a lot of Indian immigrants are, and they worked incredibly hard. And their kind of goal for us was, for my siblings, I have a younger brother and younger sister, and myself, was to go to college and to graduate school. And they valued education and really viewed that as a way of unlocking doors and kind of creating opportunities. So for us, it was 24/7. It was about doing well academically and really thinking about your career and your future and how you want to contribute to the world around you. Unfortunately, though, I think I definitely disappointed them, because I decided to get a PhD and not go to medical school. And so that was kind of a sore spot pretty much all the way through my PhD program, but I think they came around. It seems to have turned out.
Until it turns out you're telling that you're essentially affecting the doctors and telling them what to do. So I think that worked out.
So I have a PhD in clinical psychology and a background in health services research. So in graduate school, I actually did a lot of research in mental health services and policy, did a lot of work in child welfare and juvenile justice. I trained in a very interdisciplinary setting at Northwestern's medical school. That really, I think, helped me connect the dots across different disciplines and different parts of the healthcare system. It was a really kind of unique training experience. And so that, I think, was really the basis for me to be interested in public policy. But I have to say that my clinical training was invaluable. To have that experience and the perspective of being a provider and working for patients, even though I only did that for a limited time in my career, in the behavioral health field in particular, you're often working with people that are at their most vulnerable, right? They have depression, they have anxiety. I worked with a lot of individuals with serious mental illness, bipolar disorder, schizophrenia. And working with them is a perspective you carry with you, even though I'm over 15, almost 20 years out from that work. It's something that I think about a lot to ground myself, even though I'm no longer just thinking about behavioral health issues, but working more broadly across healthcare system issues. And like I said, that training experience really shifted my focus to policy. That how can you help patients and providers on the ground, and what's the role of policy in doing that? And after graduate school, I spent some time working on Capitol Hill in the Senate. I worked on the Affordable Care Act. And really at that time, that's when I got interested in the movement to value-based care as a mechanism for improving quality and outcomes and making our health system more sustainable. So at that time in 2010, everybody was talking about bending the cost curve and dealing with our twin challenges of cost and quality. And now we've sort of widened, I think, our view to say, how do we also think about value-based care as a mechanism to deliver more person-centered care and to address health equity? And so I think it's just kind of an exciting time in the value-based care movement. I think there's a lot of opportunity, and the work that we're doing at the Innovation Center hopefully contributes to it.
That's awesome. So a couple quick questions. What size was the practice that you were working at for that short time in behavioral health?
It varied. Every year I kind of went into a new setting. So yeah, one year I actually worked and in a outpatient behavioral health clinic that was attached to Northwestern's medical
Okay.
school. So pretty large clinic. You had a lot of folks with serious mental illness that had a lot of health-related social needs. So you're linking people up to housing, to food supports, nutrition supports. A lot of those folks had a behavioral health team around them. So I was the clinical psychologist, but there was a prescribing psychiatrist, mental health workers, and social workers to help them deal with, again, those food, housing, and other needs that they had. So that was kind of an intense setting, but very large and within a
Yeah.
system. A lot of those people also cycled in between inpatient and outpatient care. And so you're always kind of keeping in touch with some of the folks on the inpatient psych side as well, because these were, in some cases, folks with high levels of needs. And then I also trained in the latter half of my clinical work, and actually up at Hopkins at a place called the Kennedy Krieger Institute, where I worked with children with developing behavior disorders and attentional disorders and their families. And that was really interesting and challenging, but also so gratifying because you're working within the family system, right? You're not just working with the child, but you're really, in essence, working even more with the family and the school to really understand what that child's needs are and then wrap around them.
That's really cool. I'm sure that gave you a ton of perspective going into a government job and being at kind of a part of the world that really impacts those people. So to be able to have experiences on both ends of the spectrum has got to be really interesting. I'd love to hear about that. And so, how would you, what are some of the key differences in working in private sector and government? Because we've had some other people on the podcast that have juggled that as well. And it's always a fascinating, there's usually some fascinating distinctions there. What are the differences?
Yeah, that's a great question. I spent, I was in graduate school, and then I spent 5 years on Capitol Hill, and then I went for 10 years into the private sector where I was really on the policy consulting and business consulting side of things and really thinking about that intersection, that nexus between legislation, regulatory policy, and business strategy. So I did that for 10 years, largely focused again on value-based care. And the reason I did that was because so much of healthcare is private as well, right? It's really a public-private partnership. And so I wanted experience really understanding and learning about how implementation happens within different parts of the healthcare industry. And there, I worked with managed care plans and life sciences companies and device companies, physician organizations, large health systems. I did research with foundations. So really trying to understand the perspective of the private sector and how things actually get implemented, how care gets delivered, what are those incentives and dynamics and other pressures that folks that are running companies and businesses or nonprofit health systems, what are they facing out there? And I was also teaching at Georgetown and doing some writing as well at the time. And so I guess for me, I guess I'll talk less about the differences than not the similarities, but what I took away from that experience was that, and why I'm back in government, which is why the whole time that I was doing that work, I kept thinking to myself, what does this mean for policy? How do we develop better and increasingly more effective public policy that's responsive to the needs of patients and to the folks that are
That's fascinating.
them.
So you were like in the private sector with like a vision, with like an eye on policy. Like, okay, how does this, what I'm doing today, how do we make this better? And once you step into affecting policy a little bit, that's awesome.
Yeah, that's an interesting. Yeah, I didn't go into it with that thought, but that's where I found my mind always going. And so to me, it was sort of like internally, I realized that at some point when I had when I was lucky enough again to be able to go back into government, that I would.
Well, good for you. And I think it's so incredible to have people in government that have had experiences on both sides, because it gives you that full perspective. That's incredible. All right, so. You're on Capitol, so now you're on Capitol Hill. Do you go straight to the Innovation Center? Is that right where you started? Talk us through your government journey.
No, so I was worked on the Senate Budget Committee for about 5 years, and then after the Affordable Care Act, went into the private sector, and then about I guess it's been 17 months now, joined the Innovation Center as the Chief Strategy Officer. Awesome. And it's kind of interesting to come in, to the Innovation Center 12 years after the Affordable Care Act. I worked on the law. Have been following a lot of what the Innovation Center has been doing over the last 10 years, and then got come in and work here on these
That's awesome.
issues. So it's been amazing.
That's got to be great. So, all right. So for those that may not be familiar, everyone's familiar with Medicare. Everyone's familiar with Medicaid. People know the things that affect them on the day to day. What is the Innovation Center at the Center for Medicare and Medicaid Services?
Yeah, sometimes you have to remind us that not everybody knows exactly what CMS and the Innovation Center are. But the Innovation Center sits within the Center for Medicare and Medicaid Services, which oversees the Medicare program, the Medicaid program, CHIP, and the marketplaces. So we're talking about, touches the lives of hundreds of millions of Americans. But the Innovation Center specifically was established under the Affordable Care Act in 2010. The statute explicitly gives CMS the authority through the Innovation Center to test innovative payment and delivery models, which I know is something all of your listeners and you are interested in, and that's the space that you work in. Our models from the beginning have always have really sought to move the health system away from fee-for-service payments that drive or measure utilization, as you know, towards value-based payments that hopefully drive better health and outcomes for patients. The interesting thing about one of the unique things I would say about the Innovation Center is that if our models are able to improve quality and maintain cost, or reduce cost and maintain quality, or reduce cost and improve quality, that the Secretary of Health and Human Services can expand our model, including expanding a model nationally. So that's one of the unique things. It doesn't take an act of Congress to do that. If we meet certain criteria, the Secretary of HHS can.
Is there like a time limit? Like, is there a certain amount of time that you have to be able to prove across? Is it a matter of years? What's the timeline on implementation?
So, yeah, historically, most of our models have been run over a 5-year period. So you run a model out for 5 years, and you see, what were the impacts on cost and quality at the end of that. We know, though, from our learnings over the last 10 years, that transformation on the ground can take longer, or it takes longer to really see the impacts of investments in care transformation, care delivery, engaging patients on the ground. It can take longer than 5 years.
Yeah, especially when you're trying to go all the way back to like some of the root problems in order to see that makes a lot of sense.
Exactly.
So what do you think a more practical timeline is if it's not 5 years?
Yeah, I don't know. Probably depends on the model. There might be certain areas where 5 years is still appropriate, but we are thinking in our new set of models that we're thinking about and developing, for some of them, we are thinking about a longer time horizon. So I think primary care is like a great place. We actually had a piece that we published earlier this year about some of the key lessons learned from our first decade of testing advanced primary care models. And that was one of our findings, was that it's hard to demonstrate, cost savings with advanced primary care models in a 5-year time horizon. And so that's a place where we can say, all right, can we look over a longer time horizon and measure the impact?
Nice. So I've asked this question to many, many different people, and everyone has their own perspective on it. And I think yours is going to be unique as well. Super basic. What does fee-for-service mean to you, and what does value-based care mean to you?
It's a great question. To me, fee-for-service payment means that a provider is paid for the service that they are delivered, but I think they're also constrained by those fee-for-service payment codes. So in one way, you're incentivized to deliver the care that there's a code for, but on the other hand, when there are things that you want to do, you often can't do them, or you have to find a way to do them without that payment support. To me, value-based care is about removing some of those barriers so that you can really look at a patient, work with the patient and their family, and think about developing a care plan that's not contingent on the codes or as dependent on the codes, but really is about the type of care that they need and where and when they need it.
Yeah, absolutely. So you're saying it takes away, if everything is inhibited by codes, then it takes that away. Now a doctor can actually focus a lot on preventive measures and a lot on kind of the in between the lines, so to speak, that actually creates better outcomes for the patients. Absolutely.
Yeah, or really that whole concept of, people talk a lot about person-centered care. And I think that's what value-based care can be. Like, I don't think value-based care is an end in and of itself, that just because people are based under, paid for cost and quality, that's our end goal. Our end goal is the end user, which is the patient. And do these, do more prospective payments, more flexible payments? Do they allow providers to deliver that person-centered care. So if an individual has certain health-related social needs, all of a sudden you don't have to hopefully worry about a code and payment for that. The payments are structured so that you can spend that 15 or 20 minutes and you can build a team around your patients and your patient panel,
Yep.
right? So that you might be able to bring in social workers and do behavioral health integration and all these other things that your patients need, but that the fee-for-service architecture is not really designed with the flexibility for you to be able to meet those
Right.
patients' needs.
Absolutely. So fee-for-service and value-based care, when it comes to from an economic perspective for doctors, are basically directly dueling, right? The things that you make the most money on in fee-for-service are the things you lose the most money on in value-based care, and vice versa, right? Would you agree with that or no?
No, I don't know if it's that simple, you know.
Please
I would think
educate.
it's like, again, by case basis, right? So that at the end of the day, well, what value-based care is doing is, you know, hopefully holding or helping providers be accountable for cost and quality. Then from patient to patient, it could vary whether they're getting quote unquote, you know, an expensive service or a lower cost service. In essence, it's the service that they need. And the provider shouldn't have to win or lose depending on the reimbursement level of that service.
Yes.
And over a population, people should be getting what they need while the providers are also, you know, being rewarded for the work that they're doing and paid for the work that they're doing.
Yep. Okay. So what do you think the transition looks like? How difficult, if it's not necessarily 100% dueling, then what are the challenges with transitioning from a fee-for-service environment and world, and that's all we know, over to value-based care? What are some of the challenges?
Yeah, that's a great question, and I think we've learned a lot of lessons over the last decade on this front. I think some of the challenges are, you know, alignment across payers. So for instance, you know, we hear this a lot from folks. This is actually an area kind of emphasis for our strategy moving forward as well, as multi-payer alignment. So when you have different value-based care programs, for instance, you've got some part of your patient panel as a physician operating in fee-for-service. So you're doing the regular things that you're doing, and you know, you've got your folks helping you with billing, et cetera. And then you might be engaging with 3 or 4 other payers and Medicare. And maybe they are offering some value-based care programs and opportunities, but they're all a little bit different. So it becomes really hard to shift completely to value-based care, or you're doing it in multiple different ways and you're actually not getting the efficiencies and synergies that you would want to see. And so one of the things we've really looked at is what have we learned from multi-payer alignment efforts in our models over the last decade, and how can we really help accelerate and kind of reinvigorate this interest and move to multi-payer alignment so that we are getting those synergies and making it easier for folks to make that transition. I also think it's a couple of other things I point out is there's always a debate about downside risk and the assumption of risk and the role of risk and in success in value-based care. You know, I think one of our first strategic objective under our new strategy is to drive accountable care and to really be wanting beneficiaries and having set a goal for 100% of Medicare fee-for-service beneficiaries to be in accountable care relationships over by 2030, and that includes, right? So that's like a cornerstone of what we're talking about. But so I think there's a discussion about risk and making sure that we are creating opportunities at different levels for different providers to make those investments and move to risk at over time, in a way that, you know, when they have those capabilities and the care delivery infrastructure and the other data capabilities, in order to do so. So one of the things we're really thinking about is how do we bring more folks in, help them develop that foundation, those capabilities, and help them move over time.
And the people you're trying to bring in are the patients, the providers, the payers?
Providers, right? Because the providers are really the way to, and you know, multi-payer alignment hopefully helps bring more providers in. But we're really thinking about creating more pathways for more providers, especially safety net providers and FQHCs in particular. And then the third, that relates to my third point, and I think another barrier and challenge is for providers that have historically served underserved populations. They don't, you know, they're already under-resourced and often have populations with lots of health-related social needs and other issues and other chronic diseases. And so we have an entire strategic objective to advance health equity through all of our models. But that's another place where, again, if we want to help more providers, if we want more patients to benefit from value-based care, and we want more providers, on that pathway, then we also really have to be thinking about the needs of underserved populations and the providers that care for them. But those are some of the barriers, I think, and our strategy that is trying to address them.
That's fabulous. And obviously, it's incredible that at the Innovation Center, that's exactly what we're able to do, test these various different models, because you're not going to get it right on the first try. And obviously you're, 10 years later, you're able to look back at a lot of the data that's come in, and really, try some new programs. Even this year we rolled out a new program. But let's dig into the health equity part of it. That's obviously a really big focus nationally on healthcare today. How do we increase that? So let's talk a little bit about how value-based care can increase bringing in health equity in where it wouldn't be in a fee-for-service world.
Yeah, this is a big area of emphasis across the department. It's a strategic priority for Administrator Chiquita Brooks-LaSure, and is a core part of our strategy at the Innovation Center and how we really want to be thinking about model design. So I think it's really important that when we consider health equity, that we understand that it's critical to improving healthcare quality, which is a core mission for the Innovation Center. Looking back, we've actually learned that healthcare providers participating in our models have generally had fewer Medicare beneficiaries from underserved populations, and that they generally include beneficiaries who are less likely to live in rural areas. So that goes back to your question about barriers, right? So we know that there's a barrier to participation for some of these providers, which means that we're not able to provide value-based care to those communities and to those beneficiaries. So then the question becomes, well, how do we increase access to that accountable, high quality, person-centered care that you and I talked about earlier to a more representative group of beneficiaries? And so we are really approaching our model design and how we test new models. We really want to embed health equity into all of our models. And I think about it in the way that we have to use all the levers available to us from a model design perspective to advance equity. A couple of examples there. We have payment levers available to us in value-based care payment models. So how are we thinking about the opportunity or the potential to test ways to improve health equity, to advance health equity through different payment adjustments? We have a couple of examples that we've launched over the last year. Our ACO REACH model is our largest accountable care organization model. We have a new cohort. We redesigned it this past year and announced it in February. We have a new cohort launching in January. The ACO REACH model includes a health equity benchmark adjustment.
Talk about that a little bit. What does that look like?
So the health equity benchmark adjustment in ACO REACH, basically, it's a combination of ADI, Area Deprivation Index, and dual eligible status. And for those ACOs that are serving, the highest, or the most underserved populations, they could get up to a $30 per member per month adjustment or increase to their benchmark. For those that are serving the least underserved beneficiaries, they can get up to a negative $6 benchmark adjustment. So it's not like equal on both ends. But the idea is that it's a budget neutral adjustment. But what it does is it hopefully creates incentives for organizations to increase access in underserved areas. It also recognizes that many of those that are already in those areas have been under-resourced for decades. And so it starts to increase investment into those organizations and providers as well. We also have an enhancing oncology model that we announced in July of this year that's launching in July of 2023. That's another place where we're testing a health equity adjustment. There are care management fees called NEOS payments in that model. They're going to be adjusted based on some health equity factors as well. So that's just one example. But then, you can think about quality measures as well. Yeah. So when we're thinking about quality measures, are we picking disparity-sensitive quality measures in our measure sets so that we actually can see, are we closing disparities?
Right. What would be an example of that?
So we have some, high blood pressure is one of them. I hope I'm not botching it for our chief medical officer, but there's some examples. That's actually one thing. We have an entire quality vertical at the Innovation Center. That's what they're looking at. So when we are looking at various measures, how many of them, which are disparity sensitive? So which ones, when we move to evaluation, do we want to take a closer look at to see, again, are we closing some of these longstanding disparities in care? And then the other area I would point to in health equity, where we've been doing more work, is our health equity plans. So some of our models are now requiring or supporting organizations in developing health equity plans. So, an organization, for instance, like an ACO REACH or our Enhancing Oncology model, they develop a health equity plan that outlines the particular
Hmm.
needs of the community that they are serving, identifies, disparities or other gaps in care, and then they articulate a plan, identify some interventions for closing those gaps, and then measuring that progress over time. So that's another area. That's another way we're working with our model participants to be more deliberate about addressing equity
And
issues.
top is that a top down like who determines what those disparities are? Like, can someone in their own community, is there a way to communicate that back up to the innovation center? Like, here's what we're seeing on the ground here. Here's some.
Yeah, so they actually will be submitting plans. Um, they'll be submitting health equity plans, but it's up to the organization. They have some
Yeah.
guidance that they've been given, but yeah, a lot of that has to
Yeah.
happen locally. That can't come like
Right.
top
Kind
down,
of
right? That
defeats the
really has
purpose.
to be yeah, that has to be the organization on the ground. But hopefully, what the health equity plan does is provide the vehicle, the
Yeah.
parameters to be able to engage in those discussions at a local or a community level and to really identify the needs that of the folks that they're caring
Yeah.
for.
I'm curious, what do you think the root cause is of some of these underserved areas in the rural areas? I mean, I would say an obvious one is just people. There's not a lot of people. If there's not a lot of people, there's not a lot of medical professionals. But maybe I'm wrong. Is there anything specific that you're seeing as to why some of these rural areas there's just no doctors? Like, do you think there's anything besides for the obvious one, which is there's no people?
Yeah, that's a great question. I think you're right. The population drives where providers are
Mm-hmm.
practicing.
Yeah.
And so we've, for a long time had health professional shortage areas. And when we don't have providers, we have, these shortage areas, we also see less
Right.
investment. And, in terms of like research, for instance, like I trained at Northwestern's medical school. I mean, you think about Chicago and what a kind of resource rich area it is from like a medical perspective. And then you layer on all of the medical research and the clinical trials, and that becomes available to the folks in that community, right, or in that city or in that region. And folks in rural or underserved areas often don't have that. And so one way, so it's not an easy problem to solve and definitely larger than the Innovation Center, but some of the things we're trying to do is work more closely with other parts of the federal
Mm-hmm.
government. So we want to work much more closely with the Health Resources and Services Administration that oversees our national FQHC program. So we're working with them to say, hey, how do we get more FQHCs that are serving safety net, rural and underserved areas? How do we get them into our models? How do we make value-based care a potential opportunity for them? I think we're also thinking more about technology, and I'm sure I'm sure you have a lot to say there. But really thinking about telehealth in our models. I think through COVID, we've seen the power of
Yes.
telehealth, be able to meet people's needs and to make sure that they're getting access. That we're coordinating care. We've also recently launched a specialty care strategy that we made public in November, really thinking about specialty integration. So one example there are e-consults. What are the barriers to using them now? How can we test ways of increasing the use of
Mm-hmm.
e-consults so that primary care docs have access to, no matter where they are, might have access to specialty consultations more easily. So anyway, those are just some examples.
And I've going back to what you're talking about from bringing equity. I mean, I think it's a really good, very specific example by saying, all right, well, in an underserved area where a doctor can make more money than he would from that same exact patient in a overserved area, then that opens up the business opportunity to say, okay, well, maybe I'm gonna have less patients, but I'm gonna be able to kind of even that out. So that makes a lot of sense. Let's talk about telehealth for a sec. So yeah, obviously COVID, threw telehealth at the world. And I think everyone is loving it. I mean, I think doctors are loving it. I think patients are loving it. It's really interesting for me in my specific space of doing chronic care management to watch the shift, how COVID forced both patients and providers to acclimate to the concept. Whereas before it was like, if I'm not sitting in front of my doctor and he's not feeling me, then then there's nothing. It's not worth anything. So to watch that shift happen over a 2-year period where now people, and especially senior patients that people think, oh, they're so not tech savvy, but it's like, no, they acclimate really quickly. And now telehealth has become a really important part of patients' everyday life, and specifically in these rural areas where if they have to drive a half hour or 45 minutes to the doctor. I mean, I grew up in this small town in Iowa, and the closest hospital was 2 hours away. I mean, we once found my brother. He fell off his bike, and he was unconscious on the road, and we picked him up, and my mother was in the car for 2 hours while he kept asking her what was for dinner over and over again every 5 minutes, and she was absolutely freaking out. Yeah. So the advance of telehealth is absolutely fascinating. I think an interesting challenge that I think a lot of people don't even know exists, people that live in more urban areas, is the fact that a lot of places in rural America do not have broadband or Wi-Fi, which is kind of takes away the advantage of telehealth. Is that something at all that you guys at the Innovation Center are looking at?
Absolutely. We have I keep coming back to our strategy, but maybe that's because that's my job. But we have a third objective called supporting innovations, and that's where a lot of that thinking is happening. Telehealth is something that is a part of many of our models because we are not, we have one of the things that the Innovation Center can do is waive certain Medicare and Medicare in particular payment rules. And so we've been incorporating telehealth into many of our models because we could sort of waive some of the more some of the fee for service telehealth payment policy. And it makes sense if you're in a total cost of care construct, you're not really worried about overutilization of telehealth. You should become part of a care plan for a patient that it works for. And so that's been a part of several of our models for quite some time, and we anticipate that continuing. I think the way that we're broadening that now, like I said, is to think about, well, okay, we've been using this for some time in our models. How do we kind of integrate this to increase access to specialty care, for rural underserved areas, places that we really want to expand into. The broadband issue is a big one. The digital divide issue is definitely a big one. So when we're thinking about our supporting innovations work, that is a part of it. That how are we making data available to providers? How are we increasing access for beneficiaries? And that's something that, again, not just an Innovation Center issue, but a department-wide issue. And it's really important that we work with our partners and other parts of government to make sure that we're pushing those things forward and making those technologies available and accessible. Because like you said, when you have to drive 2 hours to a hospital, it's there is no other choice often. And so, these are absolutely critical issues if we want to reach folks.
So let's talk about member engagement for a second. I love this topic. Obviously, I'd love to hear your thoughts on it specifically. I'm sure you guys are obviously focusing on this, but I think to myself every single day, what would my doctor have to tell me to get me to go to the gym one more time, or to get me to make a different health decision? And it's honestly something I struggle with. I don't know yet. And it's something I think about every day, because at the end of the day, you're not going to change the patient unless the patient is on board, right? Unless you can really get that patient engaged. So with the incentive structure, and I think it's obviously, especially with the work that you guys are doing with the ACO REACH program and all the things that you guys are testing out, I think that it's definitely moving in the right direction, where the incentive structures trying to move closer to the patient, closer to home. How do we pull you in? How do we get you on board? I would love to hear, and maybe you don't, but I would love to hear if there's anything in the data that you see, if there's any patterns that you can recognize, or if there's any advice that you can give to how to get members and beneficiaries actually engaged in their health.
Yeah, I don't know that I can speak to a lot of data here. I'll do the best that I can, but I think beneficiary engagement is incredibly important, and I think it's an area where we want to do a lot more learning. So one of the things that we have committed to at the Innovation Center, and I think is just absolutely critical, is having more beneficiary advocacy and expert group input into our models. So one of the ways that we're trying to operationalize this is to be incorporating beneficiary perspectives and input across the life cycle of our models. So at the outset, when we're designing a model, what is it that beneficiaries and beneficiary experts and patient groups, what would they want to see? What are the challenges that they're facing, so that you're designing a payment model and a care delivery model that's hopefully addressing their needs and barriers at the outset. I would argue that's one lever that we have to be able to create a model that increases opportunities and the likelihood for engagement between the patient and provider, to your point. And that's one thing that we are doing systematically across our model development, and I'm hoping that definitely makes a difference. The other place where we're really focused on with beneficiary groups is also just communications and education and outreach. value-based care is really complex. You host all kinds of folks on this podcast. You're in that world. We talk about benchmarks and risk adjustment and all of these things, but you're hitting on, I think, kind of the core point, that how do all of those things filter down to the patient and the provider, and the ability and the capacity and the willingness of both the patient and the provider to be able to engage in their care plan. So I think some of the things that we're focusing on is really helping do more outreach and education on value-based care, what it is, why it's important, both for providers and for patients. We know oftentimes it's a term that's negatively interpreted by lay audiences. Honestly, people hear value-based care and sometimes they think cheap or bargain care. We've done some focus groups that have shown this to us.
And that was provider focus groups or beneficiary?
Beneficiary focus groups. Even some provider focus groups, they don't know, not all providers have a positive association with value-based care. And so we're meeting with a lot of providers, administrators, patient advocacy groups, patients and caregivers to really better understand what value-based care and its components, like accountable care, care coordination, quality, what do they look like in real life? And then making sure that we are, supporting folks understanding that better, educating folks, using that language ourselves, but also designing our models with those things in mind. And I hope that over time increases people's engagement in their care and gives providers more tools to be able to engage with their patients.
Yeah, absolutely. And there's only so much that you can do from a policy and I mean, obviously the education perspective is huge. That's obviously super vital. But it's interesting. One of the guests that we had on the podcast was Gordon Chen from ChenMed, and I think that they seem to be really successful in doing a great job at a full risk model, which is fascinating to me. And I've said this literally 100 times after the podcast. I've repeated this so many times because it resonated with me so much. And he basically said that, what they realized is this exact point, that if they're actually going to be successful, then they need to change the patient. They can't just be giving a better brochure and so he said that the punchline that I thought was just incredible is he said that they expended an incredible amount of resources in training their providers on persuasion just as much as they do on medicine, and to have them become experts in persuasion rather than just experts in medicine. And that blew my mind because I was like, so simple, makes so much sense, but it's an actual art, and there's this guy, Scott Adams. Have you ever heard of him? He's like the author of Dilbert comics or whatever, but he writes a lot of books, and his whole lens on life is persuasion. Like that's like his thing. And I've been trying to get in touch with him. He actually finally got back to me and said he does not collaborate with people. So you know what? He thinks he's better than anyone. He should get back in touch. But his whole thing is persuasion. And I think that like somebody like him could, I'm dying to collaborate with somebody like him who could like, okay, how do we get the patients to take their vitals every single day? How do we like introducing some persuasion tactics sounds like a scary word, but it's just a better way of selling it to the patients,
Yeah, I think about it as communication too, right? You're on a shared goal. So if the patient and the provider have this shared goal to, have, better quality of life and to feel healthier and to feel better, to play with your grandkids, to, and then you have to agree and communicate on that, hopefully the path to get there. And that's what I think couldn't be so powerful about a value-based care or value-based payment construct, that again, it's creating those opportunities and spaces for under a more flexible payment approach for providers to be able to
and I think you guys at the Innovation Center and at CMS overall have done a spectacular job with giving people the roadmap. Like I said, we do CCM and BHI and RPM every single day, right? And the biggest part of the care plan, the most effective part of the care plan, is that exact conversation. You're sitting with the patient and you're saying, let me not talk at you. Let's have a conversation. What is important to you, right? I want to see my grandkids more. That's an actual real life goal. Okay, well, what's stopping from? Oh, I don't have any energy. I'm always like, okay, well, how do we, and then, all right, well, I know that I technically need to lower my sodium intake, but I'm afraid that food isn't going to taste good if I'm eating this kind of, like, you really get into the nitty gritty, and that's absolutely part of the care plans that is super central to everything that you guys are doing. So that stuff is absolutely fabulous. I think where the persuasion can come in is for the actual care coordinator, how to sell that to the patient, how to actually have that conversation that Medicare wants you to have with the patient so that you can actually pull them in and try to, but the roadmap is absolutely there. I think you guys have done a fabulous job at that. Absolutely.
Thank you. We don't always get compliments. So
well, you are the government.
I'll take that one.
But that's great. All right. So talk about the future. What are some things that you're working on? What can we, obviously the ACO REACH program just launched. There's a lot of buzz about it. A lot of people are excited about it. what does 2023 look like for the Innovation Center?
Yeah, I'll kind of run down the list a little bit. We're excited about it too, and the new cohort launching. I think there's going to be a lot that we can learn from that model. I actually, in a lot of my talks recently, have been using some patient vignettes that we've gathered from that model, because I think it kind of pulls all of it together. Like, here's the end vision of like where we want to go, but there's one in particular that stands out at me. I'm going to do it from memory though, but it's like a senior in his 90s, in and out of the ED, has CHFs and chronic conditions, becomes a beneficiary in ACO REACH, and he ends up having monthly in-home care management, social worker support, and some education on how to use the ED. He'd been in and out of the ED. Fast forward, and the patient's reporting better engagement with primary care, a reduction in ED visits, and some really great quotes about how his care changed. So to me, that's how we start to pull all of this together to have an impact. And again, we use that term person-centered, but that's a person-centered care strategy. So in the accountable care space, we're excited about ACO REACH and seeing how the organizations in that model are doing, and how the beneficiaries with the kind of care that they're experiencing. We're launching our enhancing oncology model, which is a follow-on to our oncology care model. Really excited about that. We're testing some innovative things there. A lot of focus on patient navigation and other things there that I think will be great. We're also thinking a lot about scaling at the Innovation Center. So when we are testing models, how do we identify those successful features of our models and then find ways to scale them more broadly in the Medicare Medicaid program? So it doesn't have to be a whole model all the time. It can be successful features, and working much more closely with our colleagues in the Center for Medicare and Center for Medicaid and CHIP services to do that. Just one example from this last year is and you might be familiar with it, our ACO investment model that we tested, which really gave advance payments to new organizations that were new to accountable care. And successful features of that ACO investment model were just scaled into the shared savings program, which is a great example of how we can take those learnings and scale that transformation more broadly. There's going to be a lot of work going on, in the health equity space, as you can imagine. That's obviously an area of huge emphasis. We're going to continue to embed health equity in all aspects of our models. We're thinking about design, implementation, evaluation, and again, a continued focus as we develop our next tranche of models on how we're using payment incentives, quality measures, how we're increasing demographic and social determinants of health data collection. And I mentioned earlier, increasing safety net population, and I think we're going to have a lot more even more to show this year than last. Another place that one of the key ways for us to be successful and to drive system transformation is partnership, and that's like one of our strategic objectives, is partnering to achieve system transformation. And so that's another place where we've done a number of listening sessions over the past year. We're going to continue to hold those. We do a lot of work through the Learning and Action Network, and we're going to continue to do that. We're really developing our multi-payer alignment strategy out. So those are all the pieces that are part of that strategy and hopefully coming together. So there's a lot of things that we're excited about, including new model announcements and launches that hopefully are reflective, of this new strategy and reaching more people and more communities.
Well, it's really incredible. I do not envy you at all with the amount of data that you have to sift through to come up with these strategies and directions to go in. I could barely sift through my daily emails, let alone an entire nation's worth of health data. So hats off to you guys, definitely. And thanks so much for sitting with us today. And I'm excited to see what 2023 has in store for the Innovation Center.
Well, thanks for having me, and thanks for this great discussion.